Again, and welcome back to the Biomed Device Silicon Valley Center stage. We're glad to have you. We have another excellent session this morning presented by Nelson Labs. This is a talk on the evolution of the biocompatibility evaluation plan. Our presenter today is Matt Jorgensen, who's the Senior Extractable and Leachables Expert at Nelson Labs. Please help me give Matt a warm welcome.
Great, thank you. Can you all hear me okay? Yes, okay, great. Yeah, so we're going to be talking about biological evaluation plans. This is one of these ideas that actually, maybe it feels pretty familiar. We've had the new 10993-18 around since 2018. We were doing biological evaluation plans before that, but in the last year and a half, we've seen that the FDA has really changed a lot of their expectations for the amount of detail and rigor that goes into these plans. So it's why we wanted to highlight it today. It's something that's been pretty rapidly evolving. We'll go through it at kind of a high level at first, just talking about what a biological evaluation plan is, and then we'll get into some little bit nitty-gritty detail on some of the things that the FDA, that we've been hearing from the FDA and other global regulators with respect to this. Before I get too far into that, I always like to give just a very, very brief personal introduction. It helps me feel like we're all just chatting around like a table at Starbucks or something. So my background is actually very academic. I'm a nerd through and through. Grew up under a rock, spent a lot of time alone with my calculator. And my background's in chemistry and physics. So I did a PhD in physical chemistry. I taught quantum mechanics for a little while before moving on and doing research in materials. I've been with Nelson Labs for about 6 years. It's by far the best job I've ever had. I get to apply some of this theoretical knowledge to actually making lives better for real people, patients, and manufacturers, and the like. More recently, I've studied toxicology. I became a board-certified toxicologist as well, so I can apply that to good use. But my one claim to fame is that I helped to create a flavor of Mountain Dew. This is Mountain Dew Whiteout. That's me holding it there. This was in a commercial. Mountain Dew Whiteout is really a more smooth and kind of relaxing Mountain Dew that you might have on a patio or just chatting, colloquially about biocompatibility, something like that. For this reason, a lot of people call me Dr. Dew. I like that nickname. There's way too many Matts. If you're on a Zoom call and somebody says, "Hey Matt," there's 13 people that answer, what. So Dr. Dew is great for me. You're all welcome to call me that as well. Okay, so let's just back up a little bit and take a 10,000 foot view, and then we'll get real granular soon. So why do we care about biocompatibility? What's the point anyways, right? So it goes right to the heart of medicine and all of these things that we all really care about, right? We want to make sure, we're all in this business to improve people's lives in the end, right? And we don't want to have anything that we create actually do more harm than good. And this applies to the lab and consultants and doctors and manufacturers, all the same. So we want to make sure that we first are doing no harm with these devices. And there's a lot of angles to that, and biocompatibility as a whole is a big piece of showing that a device isn't going to do more harm than good. And that leads into this idea of a BEP where, if we're going to take this central role in making sure that our devices aren't causing harm, we ought to have an intelligent, scientific-based strategy to do that, right? And that's really the biological evaluation plan. Now, in the past, and when I say in the past, I mean way in the past, we had the old G95. This is the original table that people used to do biological evaluations based off of. This whole thing was really very plug and play, so you would categorize your device based off of the nature of the tissue contact and duration of contact, and it would lead you to a set of tests that you would perform. It was very much a checkbox approach. What was kind of, unfortunate about this time, there really wasn't an expectation that you understand your device and its inherent risks. It was more about just making sure that you pass all those tests. So we would have people, Nelson Labs has been around for a while. We see people like assemble something in their garage out of like fishing line and like landscaping parts and things like that. And if it could pass, they don't know what those materials are, right? But if it could pass those tests, great. So, to move away from that sort of thing, away from this checkbox approach, this has been refined over time. The new 10993-1 that came out in 2018 really has helped that quite a lot. You can see that there's, a few different key points there that I put on the screen. We have this revised Annex A, so that's Table A1 at the end. There's a couple of new biological, risks that have been added there. We have this whole new column for chemical and physical information, so that makes it clear, like, this is a distinct step. We need to know what our devices are made out of and how they're processed. So we ought to start there, knowing what they are, how are they processed. And then we have this idea of X's and E's, where X's are something that is totally required and E's are something that we need to understand and evaluate in order to have success. So all of those things are key points of 10993-1, the new version. Here's the table A1 from the back. I just point out a couple of things. This physical and chemical information, you can see that there. That's full of X's. That means, I'll explain it a little bit more in a minute. We have more points here, so you can see MMP was added, subacute, subchronic were split, and then you also have these other endpoints at the end. Yeah, there. There aren't any X's, but still we should be thinking about these types of risks. So it's a really more holistic, encompassing, and thoughtful process. It's absolutely not checkbox. It's not plug and play. Things like reproductive developmental toxicity, there's no E's there, but we definitely do evaluate it when that makes sense. These notes at the end explaining the X and the E are really important. X means a prerequisite information needed for risk assessment. I'm just gonna pause there for a second to highlight this theme. So the idea is to use a risk-based approach and not do unnecessary testing. We ought to understand enough about our materials to know if that testing is required. So it's that if you're going to test, you need to know that you need to test first. So it's a prerequisite to doing any testing before you use animal life. You should say, okay, this is the knowledge gap that we have that justifies the use of this animal life. Yeah, and then the E is talking about it being evaluated, and it's the point there is that it's not totally prescribed, that you can look at this. Not everything maybe needs to be evaluated. Maybe more things need to be evaluated depending on the nature of the device. Okay. 10993 is all about risk. We should be using a risk-based approach. I think that's totally clear. This is baked right into the document. You can see there. We replace Annex B with this guidance on the conduct of biological evaluation within a risk management process. And it's right there, highlighted in green. We don't want to read all of this, but we want to make a biological evaluation plan that minimizes the number and exposure of test animals. So it's completely lined up. And this, aligns with the FDA's published perspective on using a risk-based approach when you develop a biological evaluation plan. So this is from their document, that you should consider everything that you know about the device and materials, manufacturing processes, to understand the potential risks from a biocompatibility perspective. And then, you can either do testing or other evaluations that address those risks. So the FDA is aligned there. I pulled up some of these key definitions from the standard. I just wanted to highlight the last one here, this transitory contact. That was something that has come into play a little bit more recently. So we have devices like surgical instruments that might just touch a patient very briefly. So briefly that from a rational perspective, we understand that there really isn't risk to the patient. There isn't biological risk. So that is kind of nice that we can leverage this transitory contact idea. A brief period means less than a minute. So if a part of a device, like a sleeve or a handle or whatever, just touches a patient incidentally, or if it does touch, it's just for a moment, then we would say that that's transitory contact, and that really minimizes the burden that we would have in making that evaluation. Okay, so with all of that context in place, we know that we have an unwavering commitment to make sure that our devices are safe. That's why we're doing biocompatibility in the first place. We have some framework and history here. We have, history of clinical use. We have, ISO 10993-1. We have the FDA's guidance on biocompatibility. Now, we're ready to start this biological evaluation plan. So we're going to prepare to evaluate our devices for biocompatibility. This process starts with the flow chart in -1, and you can see it right there. It says obtain device material identification, and you should consider if you need to do chemistry. So it starts with this flow chart, gathering what you know, okay? And based off of that information, an expert will say, okay, because we know this, this, and this, and this, that means that we know that irritation can't be a concern. Therefore, no further evaluation of irritation would be necessary. Because of this, and this, we know sensitization isn't a concern, so on and so forth. All of that goes into this biological evaluation plan. So this is what should be in there. You should have a very clear description of the device and how it's used. I can't emphasize that enough. In fact, I'll just pause and say it again. You should have a really clear description of the device and how it's used. So many times when I get called in to interface with the FDA on behalf of a manufacturer, it's because in the documentation that they gave the FDA, it actually wasn't clear what the device even is, or how long it's used, or how it could be used. It seems so fundamental and so intimate to the manufacturer that sometimes they might not always explain it very well to somebody that's not familiar with the device. Super important. After the device and how it's used, you really need to delineate the information that you know about the device materials and how it's manufactured. So if you're going to use that to avoid doing animal tests, then it needs to be really clearly articulated. And then from there, you have justifications on why biological risks actually aren't risks, or you prescribe tests. So you'll say, because of this, we don't need to do implantation. And that evidence is there inside the biological evaluation plan. And then if you do need to test, then the test parameters really ought to be specified if there are special test parameters. So for example, if you have a set of 13 catheters and you don't want to test all of them, then maybe you may test the biggest one with 13 colored end caps all put together so that it's like a master device that represents all of them. So if you're going to do a strategy like that, it should be written down and part of this document so it's clear down the road that this is what you did and why, right? And there's other ideas there, right? So like master products or if you're going to do coupons or like pieces of the device to exclude or include, all of that should be part of this plan. So as I said at the beginning, this is something that's actually been evolving quite a lot. For us, the expectation on a BEP from the FDA has increased. These used to be like 4 or 5 page documents for something like an orthopedic device. Now they're a little bit more like 15, 16 pages because a lot is expected in terms of the level of detail for the materials and manufacturing processing, and a lot more detail if you're going to avoid doing a biological test. Okay. So now that we have this overview of BEPs, what they are, the fact that they've been, the bar has been raised on them over the last year and a half, let's just talk about a couple of specific things that we've heard from the FDA and how that can kind of play out. So one of these things that we've heard is this shelf life concern. So you make your biological evaluation plan, you test, you do a biological evaluation report, it gets submitted to the FDA, then they might say, okay, this is great, but you evaluated the device while it was newly manufactured. How do you know that it doesn't change as it sits on the shelf before it gets used? So this shelf life concern. And I want to point out that this is different than like end of life evaluations for reprocessed devices, for example. So if you have like an endoscope that gets cleaned over and over, that's kind of one thing, because we know that this cleaning process can be aggressive on those devices. This means as it sits passively on the shelf, how do you know that the thing doesn't change? And the explanation for a very long time has been that, well, we know that devices generally are the most risky when they're newly manufactured because they're so proximate to the manufacturing process. They're more likely to have volatiles and semi-volatiles that would outgas slowly over time as they sit on the shelf. So therefore, it's more likely that they're riskier when they're very young. But there's been a couple of great examples where that's been contradicted, and I think that's why the FDA is so aware of this. So the example that came to mind first was the one that I have on the screen there. So imagine this. So this is one that came across my desk. So we were at the height of the pandemic, and it was that time when there was this mask shortage, right? Nobody could get an N95 mask anywhere. And inside Nelson Labs, we were doing everything that we could to figure out how to reprocess disposable N95 masks. So at the hospital, people could at least spray them with IPA and use them one more time. So in this environment, a big customer found 100,000 or 200,000 reusable, disposable masks in their warehouse. Yeah, so they're like, okay, there's a mask shortage, this is a crisis, let's pull those out and use them. The masks were expired, but they weren't just a little bit expired, they were a lot of it expired. So they had a shelf life on the box of 4 years, and then 4 years ago, they had evaluated that and extended it for another 4 years. So now they were just over 8 years old. So they released those masks, they went to hospitals, nurses were using these and complaining of respiratory irritation. So they would put the mask on, and then they would have a coughing fit. They would feel burning in their lungs. There was all of these problems. And it wasn't just one complaint. It was 30 complaints. Yeah. And so usually when this type of thing happens, that's when they come to somebody like me. They're like, okay, look, here's what's going on. This is why we released them. People are complaining. What happened? What's the deal? And so this is a case where as it sat on the shelf, things can change, right? So it turned out that this the foam nose piece there that's intended to avoid having your glasses fog up. It adds a little gas barrier there. So that was polyester. Polyester slowly hydrolyzes over time, right? And as it slowly hydrolyzes, it can make fine particulate. And polyester particulate, if you inhale that, then now it's in the moist environment of your lungs. If you hydrolyze polyester, you make these carboxylic acids, and it's a really irritating type reaction. It's actually makes total sense why this should be a respiratory irritant, right? But it only happens if it sits there and ages. So, and you can see this isn't the only example of a polyester foam aging causing a biocompatibility problem down the line, right? So if you start to Google search for some of this isn't a unique case. So that's an example where we think that devices are the most biocompatible when they're virgin, but that's not always the case, right? And there's other things that you can think about. So another really good one is blood contacting catheters. So this is one where it's good to take a step back and really think about, do we know how biocompatible this is or not? So blood contacting catheters, they need to be made out of plastic. They need to be very soft to do their job. That means that they have plasticizers and additives in them. As they sit on the shelf, those plasticizers and additives slowly migrate to the surface of the catheter. It's called blooming, right? And so then what you can see on catheters that are set on the shelf 2 or 3 years, they can have this sort of foggy waxy kind of coating on the outside. And that foggy, waxy coating can cause platelets to adhere to the surface a little bit more, and there can be a thrombogenicity concern. So this is a case that happens, I don't want to say adverse events or something like that, but we see these types of cases where people have pulled catheters off the shelf and they see this blooming, and it's a question like, okay, is this safe? Because we know when we tested it, there wasn't this blooming on the surface. Yeah. So very long story short with this example, in the BEP, this should be considered. So do you know that the biocompatibility of the device is stable over time? If you do know that, why? If you don't know that, what are you going to do to ensure that it is actually stable over time? And in some cases it's super duper clear. Think about something like a 316L stainless steel knee. So we know the oxidation profile of 316L stainless steel and those characteristics under all sorts of different conditions. And we know that that surface is stable over many years. So that's easy to say 316 doesn't change as it sits on the shelf. For other types of plastics, we also know that it's stable. And you can find some literature references to put in there to support it. But if you start down this path and you're like, okay, does this polyester foam stay okay over 4 years on the shelf, and you can't really answer, then it's time to say, okay, we're going to evaluate that. We're going to do an accelerated aging study, and we'll test, run these tests targeted to the risk just to ensure that our polyester is okay. So this is part of our part of BEPs today that wasn't part of a BEP a year and a half, 2 years ago. I think that the FDA, I give the FDA a little bit of a hard time sometimes, and I really, really shouldn't, because they have a very important job. This is a case where I think that they've been smarter, right? So it's like when we see devices that could have this type of risk, they've been a little bit better at recognizing that and pulling it out. So it's something that I would view as a requirement to address the shelf life of the device. Okay, extractables testing. This is another area that it has been super high focus for the FDA and really rapidly changing. So it's different today than it was 6 months ago, and what we were doing 6 months ago was very different than a year before that. There's really a lot that we could say about extractables testing, and actually I have a tech theater later. It's just about stuff we hear from the FDA on extractables testing, so we won't get too deep into it here. I'll just say just a little bit. So extractables testing is usually part of biological evaluation plans when long-term systemic toxicities need to be addressed, because we can address these toxicities better by understanding what extractable compounds leave a device and knowing how those compounds could be exposed to a patient. With a toxicological risk assessment, we can take that data and make a claim about something like carcinogenicity. So this is why it's part of that in the first place. The FDA is very specific about how they want this study to go forward. It's a subset of what's written in the standard 10993-18. So you can't just comply with the standard. You need to comply with the FDA's special interpretation of the standard. So if it's prolonged or long-term, it's got to be 50 degrees C until exhaustive with a minimum of 3 solvents. You can't compromise on that. Even if these conditions don't make sense, you still have to do these conditions and then do something else after. The sensitivity to the FDA is very, very important. So the sensitivity of this chemical analysis can be an absolute deal breaker. I've seen and been on calls with the FDA where this was the factor that kept a device from the market at the very, very end. They was like, sorry, that AET was just not quite low enough. And that's it, case closed. Let's retest and resubmit. So this thing, the sensitivity of analysis, is super important. You ought to specify it in the BEP. We do, and you ought to be really, really sure that that's sensitive enough to satisfy the FDA and your toxicologist. Really, the toxicologist should inform what the sensitivity should be. And then the final thing that I want to say about extractables testing is, so 2 years ago, 3 years ago, we were recommending this almost all the time. It's like, what's the problem with getting more data? Everybody loves data. We're all scientists here. But actually, today I'm much more cautious, right? So there's definitely situations where people say, hey, let's do E&L. And I'm like, no, actually it would be much better for you to not do E&L in this case. So there's cases or times where doing extractables testing will harm you. And it's good to know when those times are if you have devices in certain categories to avoid stepping into that, pothole. So know when to say no. There are times where it's not right to do. So explaining when testing isn't necessary. I brought this up before. I want to highlight this text here, that it's just clarifying that a little bit. So if we're going to claim, so there are cases where we can claim that testing isn't necessary. We actually do it pretty regularly. There can be sound cases for that. It's when you can specify the material and its processing really, really accurately, right? So if you have an all-metal device, then this actually becomes pretty simple, right? So if your device is made out of TI6AL4V and that conforms to some ASTM standard, that means that we know exactly what that material is. Yeah, and then if it's passivated to a standard and you know that the device is clean, then this is kind of like case closed for the FDA. And for me, it's like, okay, we've tested TI6AL4V 1,000 times. We probably have it on test right now. We know that this material is biocompatible. If you prove that there aren't residuals on there, then that's even better. The manufacturing is not a concern. So if you're going to do this, all of this should be explained in the BEP, so it's crystal clear, both to yourselves and to any regulator that you're going to give this to. This is why those risks are a concern. It's a lot more challenging if your device has plastic anywhere in it. Plastic epoxy parts are tricky. Even if the plastic part is very well characterized, there's lots of weird questions like, how do you know that the upstream suppliers haven't changed since you adopted this material? And how do you know that your manufacturing process isn't changing it? Things like that. I'm not saying it can't be done, but it's much more difficult to do if you have a plastic device. Okay, so what do we do with these BEPs? So that's kind of like this framework. How should you use this document? I wanted to point out just a couple of things that you should do with it. One thing, and again, maybe it seems obvious, but it's not always, right? So sometimes we make BEPs for companies that have devices on the market that don't need to submit to the FDA or any regulatory body. They've just never had a clear description of the biocompatibility of their device. So a lot of times it's for internal consensus inside companies where there's some regulatory office that's saying, okay, look, we're going to do this and we're going to all agree this is our strategy for biological evaluation and this is why our device is biocompatible and so on, right? So sometimes it's just for internal use. Other times it's to give to the FDA as part of a pre-sub. So we see people, they know that the FDA has been kind of skittish and like changing their mind about the strategy with chemistry and things like that. So they want a little assurance that, okay, FDA, will you accept this strategy that we propose in this biological evaluation plan? So they'll do that with a pre-sub. That's something that we've seen a lot more frequently. We do a lot of it at Nielsen Labs. We can submit pre-subs on your behalf and things like that. And then obviously it's used as a roadmap. So if you are submitting for a 510K and you're not going to give it to the FDA as part of a pre-sub, then it's the roadmap that you give to whatever testing lab that you're going to use. You say, okay, look, these are the tests that we need. This is how the sample should be, and here's why. And that goes and it informs all of those tests in the end. So if it is for a pre-sub or a Q-sub, this is the type of document that you fill out. Like I say, this is a free program that the FDA does. You just got to get the form 3514. You submit it to them, and you get their free feedback on that plan. So this is something that we do quite regularly. Okay, with that, I may have finished exactly on time, but I wanted to leave a couple minutes for questions. Any question at all about biological evaluation plans and crazy stuff that the FDA says, I'm happy to answer. Yes.
What's your interpretation on the distinction between the BEP and the BRA?
Yeah, so the question was, what's the difference between a BEP and a BRA? Both of them are pretty similar in the fact, or in the sense that they're evaluating the biocompatibility or what might be needed to address a biological risk. Usually we look at a biological evaluation plan as something targeted for a fresh evaluation or a new submission, right? So if I was going to submit to the FDA a 510K, I would always use a BEP. Now, if you might not submit, let's say that you're making a small change. So a common change would be that your upstream supplier for a polymer is changing one of their suppliers, right? So it's still the same polymer, still like tecothane, but tecothane's maker has an upstream supplier change. The question is, does that change matter? Will that affect the biocompatibility of our device? And so then we would call that a biological risk assessment, where we say, okay, here's what happened. Is there a risk? Well, yeah, there's a potential risk to this change. Does that matter or not? Does the biocompatibility of the device change? So that type of a thing. So it's a lot more common with like a change assessment. But they're, can interchange them a little bit, for sure. Any other questions? Yeah.
Here, I'll bring the microphone over.
Thank you. So during your presentation, you mentioned there are times where doing ELNL may not be helpful. Can you speak to what some of those circumstances are?
Yeah, sure. So the question was, so if the answer is no to ENL sometimes, can we have a couple of for instances? Absolutely. So anytime the device doesn't have a long duration systemic toxicity indicated per 10993-1, you really should hesitate. So think about any limited contact duration device. If you generate this data, you have to assess that data somehow in the end, right? One way or another. And so just to give you an example, I have right now on my desk a device that contacts circulating blood, but it's limited. And the makers of this device have already done all the biological testing. So they did the big three, acute systemic, MMP, and they did genotoxicity testing. And in addition to that, they did extractables and leachables. But as a toxicologist, I have this huge, massive data, and I'm like, okay, well, I don't need to assess this for chronic tox because that's not a risk, or subacute because that's not a risk. I could assess it for genotox, but it already passed that test, and I don't want to contradict a test that's already been conducted either. So really, there's nothing I can do with this data. Yet, when they go to submit to somebody like BSI, they still feel obliged to share that data, and BSI insists that they have to assess it, right? So what it can do is generate a whole lot of information that nobody knows what to do with. BSI doesn't know what to do with it, FDA doesn't know what to do with it, I don't know what to do with it. It's like, it's there, it's informative, but there's no risk to apply it to that hasn't already been evaluated. So that's one. Another one is wound care devices. So these are like any biologically based wound care device, like a decellularized matrix, like collagen thing. This is even if it goes into prolonged duration, is a nightmare for chemistry. It's like a rabbit hole that you really don't want to go down. So I would say that's another very clear example. For those, you say, chemistry is not the right fit for this device type, and you should do the biological testing. It's a great question.
Additional comments or questions? Don't be shy.
Cool. Well, then I think we're good.
Okay. Thank you, Matt. Thank you for
Thank you,
coming
everybody,
out
for
today.
coming.
Hope you enjoyed the presentation.